Welcome back to Vet Wrap. Today's session, is Dr. Alasdair Renwick. Still Victoria's only
orthopaedic specialist in Victoria.
Dedicated orthopaedic specialist in small animal surgery, of course. Yes. I think you're well known, so that's enough of an intro.
Yep, cool.
Today, Al, you wanted to talk about a bit of a passion of yours. That's why all these bones here. Bones. And but specifically 3D printing. Is that correct?
Yes, yeah. Absolutely. So I guess, you and I, similar era, aren't we? We're kind of old enough to remember that when we used to do angular limb deformities, so growth deformities, you would typically hang the leg in theatre, you would cut the bones, you had no idea what was going on inside, you would put an external fixator on and, you would hope that it would heal. And it was all very uncontrolled.
Heal and be straight.
And be straight, exactly. And be functional. Yeah. And I guess the problem is with those deformities, they were very complex.
Yeah.
And why we recognize there's lots of complications sometimes with external fixation, we had no idea once we cut this twisted, bent bone and straightened the leg, would it even be possible to put a plate on these things? There's just no way to know. And so I remember then that's what we were doing. And I remember probably, I think it's the early 2000s, this paper came out from America and they described this technique called stereolithography, which was a method of taking a CT scan and then turning it into a 3D model of the actual bone. And I thought, wow.
On screen though, wasn't it?
No. Actually,
they actually printed it.
Stereolithography was actually printing the bone. And I remember reading that and thinking, that is amazing, but that will never happen out of a high-end university situation in America. And of course, fast forward 20 years and now we have, desktop 3D printers. So it's quite amazing. I don't know why, for some reason, the term stereolithography didn't really take off. 3D printing is how we all know it. But I guess the first thing is it allowed us to actually look at these deformities in a way we'd never been able to.
Can I grab you there? Because one thing, because I always go off script, also, what I remember, though, is that we started to get a lot of publications describing how to actually measure the deformities. So not only did we have this new technology coming along, we actually started to recognise that bones weren't bent in one location, often had multiple bends and torsion, and that our capacity to really accurately document the deformity was really quite limited, particularly with radiography. So CT sort of was part of this journey, do you reckon?
Yeah, no, absolutely. Yeah. And the understanding that it's more than just the foot pointing in the same direction, that you can still have significant issues if you don't have a better limb. So absolutely. Yeah,
that's cool. Anyway, so we got 3D printing.
So we got 3D printing, and the first thing was just the ability to actually hold these things in your hands. This is an example here of a typical angular limb deformity. It's got a bend, a valgus, it's got a procurvatum, it's got a torsion on it. And no matter how you look at this on an X-ray or even a CT, the ability to actually hold this in your hands and understand it is massive.
And these are real size too.
Yeah, this is real size from an actual patient. So we can take the scan, we can convert the scan into a 3D printing file, and depending on the type of deformity, we can send these to a veterinary specific manufacturer, or we can just locally print them. But they're real size, and that's the key thing. So. And they come in different materials. We have to be careful if we're using these in theatre. They have to be biocompatible depending on how we're using them. So, you can see two different materials here. This is one that is allows you to actually cut it, whereas this one here, you could not cut this. But we'll use this for other modeling aspects of it.
Yeah.
And so, we first of all, we've got this thing in our hands now, and we can go, okay, I understand this deformity better. You can then do your plan. You can with a CT or with an X-ray, you can measure some angles now. We know much more accurately what we're aiming for, and then you can actually do a practice surgery.
Yeah.
And that's been
that's been
game
awesome,
changer.
hasn't it? Yeah.
So like this model here, we've actually now done the surgery on this.
Yeah.
And you can see, well, that was what I planned, and that looks not bad. I mean, they're never perfect, but
isn't, I reckon, so if you hold the two models, I reckon that's also one of the things in history is we'd have that dog, and then we get the X-ray and make it bigger, and then plan, and actually go into theatre feeling super confident that it was all the plate was going to fit on.
Yeah.
And the thing shrunk.
Yes, yeah. You're like looking at
remember that? Yeah.
microscopic thing in your hands going, what was I thinking of?
Yeah, exactly. Because on the X-ray, it was 4 times bigger than...
Exactly.
Yeah.
Exactly.
So that whole, for me, that being able to hold actual size really sort of helped me focus, this one's sort of a simple anomaly, but a tiny bone.
Yes, yeah.
Now, you say that one's sort of, you've corrected that, and put a pin in there. See, I look at that one and there's lots of things in my head. I don't look at that and think that's super simple. The deformity was, but doesn't it show you how your plate contouring, because you've got torsion on that?
Yeah.
That's going to be tough, isn't it?
Absolutely. Yeah. I mean, I suppose the other thing that's come in tandem with this is the use of locking plates.
Yeah.
So we used to have compression plates where if the plate didn't fit perfectly to the bone and you tighten the screws, the bone's going to move and you've lost your reduction. So now we've got the ability that you can put a plate on that's relatively contoured and it will just keep the bone where you put it.
In the right spot, yeah.
But there was always still the problem of, well, could you, if the bottom of the plate is on the bone, is the top of the plate going to be on the bone? And that's what the models have allowed us. So now we can, pre-contour the plate the day before surgery on the model.
Yeah.
And then when you go into theatre, it's going to fit, which is very rewarding.
Yeah.
But probably more importantly, it's another checkpoint that if you've done your correction in theatre and then the plate doesn't fit, something's not right. And it's just an extra sort of safety measure.
And it also allows you to use the plate to actually help you get the reduction that you wanted.
Exactly.
Yeah, so it's not only a checking point, it's application of the plate puts the bone in the correct place because the plate actually fitted because you practiced beforehand. Yeah. It's very cool.
Yeah, and I guess we all know with surgery, what's the critical thing with the surgery is time. The longer we're in there, the greater the risk of infection. So this all being able to do all of this stuff before you pick up the scalpel is huge. So it actually massively reduces your surgical time. You're doing stuff out of theatre with a dog that's not anaesthetized. So it's it's a huge benefit. So and I think you and I probably both used to always use external fixators for these limb deformities, and now there's a few specific cases where we would still do that, but the vast majority now we're internally fixating with plates and screws because we can do this, and that's improving the patient comfort. It's much simpler for the owners after surgery. It's a much easier thing to discuss with the owners as well. It's just going to be all internal. You don't have to worry about this framework on the outside of your dog's leg for the next 8 to 12 weeks.
And in some regards, I think it reduced costs. Like X6s are slightly cheaper the day you put them on, but that ongoing cost, very hard to estimate for, isn't it?
Yeah,
it can be really quite substantial and it can lead to significant frustration on the owner's behalf.
Yeah.
So it is. It's lovely to be able to get a plate in, get it done, and the process has happened. Now it's a case of just recovering.
Exactly. So I guess that's the first thing that
was the first wave.
The first wave of and then the next wave is then, well, can we make the osteotomies more accurate? And because with this we're still planning it on often on 2D on CTs or X-rays, but there's still then the step of, well, you have to replicate that in surgery. So it's one thing to make a beautiful image on an X-ray or a CT, but do you actually achieve that when you go into theatre?
Yeah.
And so much more recently now, we've got this advent of 3D printed cutting guides. So like,
and just because the technology, that sort of was a software step up, wasn't it? Because we could print the bone and we could model the bone in 3D, but we then had to create a way of adding on and contouring around that available model.
Yeah, exactly. Yeah. It's a software thing. It's also an understanding and an expertise way to do this. And we now have specific people, specific companies that we can then have a discussion with, and we'll go through, well, what do we want to achieve with the deformity? How do we want to correct it?
Yeah.
And they can then actually create a device that will allow us to execute that plan very accurately. You can,
but like a shout out to Bill Oxley. Like, how many years has he been really doing this? And like, his service is phenomenal, but it's not like he just woke up one day and said, I'm going to create a cutting guide.
No.
I mean, the years of experience are quite substantial.
Yeah, Bill and I knew each other in our residency. What's that, like 15 years ago?
Yeah,
and
well, 2.
Okay.
We're younger than that.
Yeah, of course, yes, last year, and Bill developed a passion for this towards the end of his residency.
Yeah, that's right.
And he's probably done more work on this than anybody else. And he's often the company Vet 3D in the UK that we would use.
Because that part of the planning is essential and can be extremely complex. Because I've sent a dog off, a CT off, got a limb printed, and it had a complex deformity, and then they sent me back some printing guides, and they were way off.
Yeah,
like it didn't work at all.
Yeah,
and because of the style of deformity that the dog had, and at the time we didn't really have a system to manage. The software wasn't working, or maybe we hadn't worked out how to get it to work.
Yeah, exactly.
So
and
now,
I've had exactly the same thing. You waited 6 weeks for a guide, it comes back, and you look at it and go, that's not what I want to do.
Yeah.
And so having somebody that is also an orthopaedic specialist that understands how the best way to execute these are is incredibly helpful.
And those years of experience have got us so much further forward with what we can actually recreate and accurately deliver on these more complex deformities.
Yeah, and if you look at the images here, you can see what we've got is a guide that fits perfectly onto the model of the leg.
Yeah.
And we secure that in theatre with some pins, so it locks that guide to the bone. And then you then use that guide to make your osteotomy. And the other thing, I mean, historically, I don't know how your brain works. My brain only works in 2 dimensions. So I can think, craniocaudally, I can think medial-laterally, but I can't think, how do I make an osteotomy that's 30 degrees between those 2 planes? These deformities are like that. They're oblique plane. Or they can be multiple deformities in the same bone as well. And my brain just can't handle that. So what these things allow us to do is we can lock a guide that allows us to make a complicated wedge that's in an oblique plane that fits exactly where the deformity is. The center rotation angulation, the cora, allows us to put it exactly where. And so that's what you can see in the image here. You can see that image on the right. This is the cutting guide secured to the bone on that oblique plane deformity. And then we'll use that guide to then make the osteotomy, make the cut. And then we take the guide off. You've now got 4 pins there. And then we have another guide. So that's this is the guide you can see here. And this then fits beautifully onto the reconstructed bone.
The straight bone.
So we planned it. Well, this is what the bone's going to look like at the end. And so you use those pins and pull that bone back together using that guide.
And that's how smart people like Bill have got, isn't it? Because the pins that you put in to secure the cutting guide are then the pins that you use for because we'll call that a reduction guide. So essentially, he just stops human error, doesn't he? Because you have to put the pins in to hold the cutting guide.
Yes.
So they are in fixed position now.
Yeah.
And you have to reuse those.
Yeah, and not only that.
And so you're not adding a new pin later on.
No, but not only that, we then have to think about, well, where's the plate going to go as well?
Yes.
So before you even design the guide, you look at the completed bone and you go, well, this is where I want to put the plate. And then you know the trajectory of the screws in the final plate. Then you have to go back to where's the guide going to go so the pins don't interfere with where the plate's going to go. So there's a lot of
so much to think about. Yeah. And I guess that's why I sort of mentioned, Bill, is that part of what we do, or what you're doing with these 3D printing and guides, is you need to have the relationship with the people that know what they're doing, because there's an absolute trust when you send a CT off to Bill that he'll model it and design the cutting guide and the reduction guide, and that he knows what he's doing and what comes back will work.
Yes, exactly. Yeah.
And isn't that equally cool? Just for the camera though, I mean, same dog, same leg. This one's obviously bowed here. This one's nice and straight.
Yeah.
It's like a prehistoric club, isn't it?
Yes, yeah. And then you can see in the image as well. So this is the plate contouring. So that plate, I mean, this is an unusual deformity, this one, but that plate spanning the whole length of the bone. And we can see, it's shaped nicely. It's quite a complex curve I had to put in that plate.
Yeah.
And then when we go into theatre, you can see now it's, just like the model. It's exactly like the model was. And the plates that we pre-contoured fit absolutely perfectly. Yep. So, really rewarding, really satisfying. So the
side before is the day before.
Yes.
Yeah.
And this is
that whole idea, reducing surgical time because you get to do all that outside the dog. Yeah.
Exactly. And then, ending up with a result that is, probably much more accurate and safer than I would have achieved if I'd been doing it freehand. Which is
absolutely.
And I guess it's worth pointing out though that not every case we would need to go to this level.
Yeah.
I will still freehand some of these cases, or for I say freehand, I'll still use a model.
Yeah.
But I'm maybe not going to the extent of the cutting guides, because some of them are simpler, and we can. Because there's a cost involved in this, and we always have to have this balance between, well, what's the benefit of the technology versus the cost to the client? Do we think we can achieve this result without adding that cost on, or is the benefit of that cost is worth it? And that's always the balance that we have. Yeah, so
absolutely. So there's a next generation.
Yeah, exactly.
Yeah. So it keeps going.
Yeah, it gets even better. Yeah. This is a nice, example to show. This is a case that we treated in the last couple of months here, and this is a sort of 50-kilo dog with this really complicated smashed distal tibia, and this fracture is going into the articular surface. So he's lost his joint surface, and just the mechanics in trying to stabilize this are huge. And so this dog actually needs an arthrodesis, but there are no plates available to try and do an arthrodesis in a situation like this. So, now we have the option of these. So this is now a 3D printed titanium plate, which is made specifically for this bone. So we send off the CT, and then what we have then is, again, guides that fit the dog's bone. But this is now screw guides. Yeah. So we design the plate on the opposite leg. We sort of mirror image the opposite leg. That's where the plate wants to go. Yeah. This is where the screws are going to go. We can then choose where the screws go in the plate. We can choose the angulation of the screws. We can make the plate have those angles, and then we can have these guides that fit the dog's leg, so that the screws all go in the equivalent angles in the bone. And then when you tighten up the screws, then hopefully everything's
works in the right spot,
works nicely. And here we can see now the plate actually on the dog, and this was a massive operation.
Yeah, I was going to say there's so much planning with this dog,
huge amount of planning, and a delay. Yeah, and that's this was
as well.
Over 2 weeks delay managing this dog. To get to this point. And you were involved in the discussion as well. Like, what other ways could we do this? But ultimately, we came to the conclusion this is the best way to treat this very unusual case. And this dog is, it's now 8 weeks post-op, and he's walking amazingly well. So, I think this would have probably been a euthanasia case if we hadn't been able to do this. So,
No, he's he's a huge case, but a huge undertaking. Yeah, it's not like these are, you got to be super committed if you're going to take on this sort of challenge. Yeah,
absolutely. Yeah, and it's even with the guides, this was a multi-hour surgery,
absolutely.
Very complex surgery to actually get an implant like that into the dog's leg and end up with a good result afterwards. But but hugely useful.
So just sort of backtracking. So we've really gone. The first step for me actually was being able to, and that this has been around for ages, was CT and being able to create an on-screen 3D model.
Yeah.
But then the printing side of things was being able to print it and hold it in your hand. And then the next gen was, the capacity to accurately correct the angular limb deformity on screen, which led to being able to make cutting guides and reduction guides.
Yeah.
And then this is sort of where we've ended up, where we can actually print the implant that goes into the patient.
Yeah.
But it's not perfect yet, is it?
No, it's not. And I think the question that people always would think is, well, why don't we just 3D print every plate?
Yeah.
There's a lot of science goes into metallurgy about how do you make the actual metal and the design of the plate strong enough to withstand the forces. And, some of these 3D printed plates may not be as strong as a specific manufacturer controlled designed implant.
Yeah.
And the second thing is, at the moment we can't have locking screws in custom made plates.
Yeah.
So we often want that thread cut into the plate with the corresponding thread in the head of the screw. And we can get that in the manufacturer-made plates. There are some specific manufacturer-made 3D printed plates, but they're not for the individual dog. They're for like a generic Spaniel or a generic French Bulldog.
I was going to say that there's been this offshoot, hasn't it, where there's this 3D modelling has led to plate designs based on 3D modelling.
Exactly, but they're not the actual patient.
That's right.
So those plates allow you to have locking screws, whereas in this example here, these are cortical screws.
Yeah.
So which is probably why I think there was 25 screws in this dog. I mean, it's a massive, it's a big day out. And that's partly because we can't use the locking screws, so we need to really beef up the technology.
Yeah.
So
the security.
Yeah.
Cool.
Yeah.
It doesn't stop there though, does it?
No,
we have another application. Well, we have many applications.
Yeah, there's many. I mean, I think the other big thing is spinal surgery.
Yeah,
and
this guy here.
Yes. So I mean, again, you and I will remember when we first started doing these. Vertebral body screws. Yeah. It was Russian roulette.
Terrifying.
Yes, exactly. You've got a spine, and if you put the drill one way, you'll go through the spinal cord. And if you go the other way, you'll go through the aorta. What could possibly go wrong? So,
and it was always on a weekend with a spinal fracture.
Yes, but also even if you don't end up with that catastrophic complication. And I mean, literally, it was like 4 screws and pray before each screw. But not even just the immediate complication in surgery, but just the amount of bone purchase you can get.
I always forget the proper term for that because obviously a bunch of publications again looking at safe corridors, but then the ones that weren't. They were safe, but not as good quality. We had a term for that, didn't we? Or not? No, but they're all. There's a numerical grading as such. That's right.
Exactly. But how good are they? Is it catastrophic or is it? It's not catastrophic, but
it's not great.
It's not mechanically great.
Yeah.
And so, what this technology, similar sort of idea. So here we have a dog's sacrum, and then we have a guide that fits into that exact dog and locks into the bone, and then that allows us to angle a drill so the drill hole ends up exactly where we want it to go based on the CT scan. And so it means that you're in much better quality bone. But the other thing is you can actually use bigger implants. The most recent one of these, I used a...
So that's a lumbosacral fusion for degenerative lumbosacral sclerosis.
Yeah, exactly. So this would be a sort of, 40 kilo German Shepherd, I think that dog was. So, But I mean, recently I used a 5.5 locking screw in one of these, and I've never used a 5.5 locking screw because you'd never be able to safely get that size
you
of
certainly
implant
wouldn't feel confident doing it.
No, well, exactly. You would. Yeah, there'd be significant risks of fracturing out. So it allows us to more accurately place them, but also use stronger implants which are going to not break. So and you no longer have that terror when you're doing it, and what it means is that then we're more optimistic with the owners. So there's probably dogs in the past that we would have said, look, it's not worth these 20% risk of something awful. Now that risk is a lot lower, so it's a lot easier for us to now say, hey, you should maybe think about a lumbosacral stabilization because it works, and we've got really good technology for it. So I mean, we still have the problem of what happens when the spinal fracture comes in on a weekend, and there really is no way to have these made at this point in time. Yeah,
but remember not so long ago we were having a conversation at Rounds when we were doing Journal Club about was all this 3D printing, was it actually de-skilling surgeons because we didn't, we now rely on the guide and we rely on the 3D modelling on the computer set. But you quite accurately pointed out it's actually teaching us.
Yes.
Because it's teaching us where the most appropriate positioning is.
Yeah, exactly.
I mean, this lumbosacral fusion's been done for eons and the landmarks were known, but you had to go to a book and sort of scratch your head a little bit and go, looks like it should be about there. Now you've gone into surgery that many times with a guide. It's like, actually it's a little bit this way and a little bit that way, and your accuracy without a guide would have to be improved because the guides have taught you.
Absolutely, because you and I know there's a big difference between what a textbook looks like and you go into surgery and you're like, is that the right landmark?
Exactly.
That must be it. So you put your implant in there and then you get your imaging. It's like, it's not quite where I thought it was.
We sort of had to learn by critical review post-operatively, whereas now we're learning intraoperatively as well as post-operatively.
Exactly. And if you're in that situation of, is that the right entry point? And then you put your guide on and the guide doesn't fit. You're like, okay, no, that's the wrong place. You just keep going. So absolutely. I think it's teaching us, it's teaching residents. This is the exact entry point of the screw, and then this is the angulation of the screw as well.
But it's also teaching us on even the more simple angular limb deformities because we get such a accurate reduction of their deformity. It's back in the days of the X-fix and hanging the limb and making sure the paw pointed in the right direction, you really didn't get as good a feel for what it should end up looking like.
No.
And even these concepts of the core, like how far up or down the leg is the angle of reduction of rotation, the guides tell you exactly where that is, and you start to learn a little bit from in that circumstance as well. I certainly noticed that when I started using guides. Like, okay, it's slightly different to what I anticipated.
And I think that's there's the idea that if we're using this, we're just passing all the work on to somebody else. But it's not like that at all. It's very much a team process and working together to look at these deformities and go, that's how we want to fix it. And we every case we all learn from it. So.
I can't emphasize that you do have to have the relationship with the person operating the software in the background and designing or engineering your surgical reduction. If you don't have that, big problems can happen.
Yes, absolutely.
It's very cool.
So, I mean, I think for me, the journey of this has been fantastic. And, as a surgeon, these are, we do surgery because we like doing surgery, don't we? And these things, they are, as a surgeon, they are fun. Let's not be honest. Let's be honest. They're great to use. But the reality is, it's giving us, quicker surgery, more accurate surgery, and better patient outcomes. So it's great for us, but it's a heck of a lot better for the patients as well. So it's an absolute win-win.
It's that lovely outcome, isn't it? Everybody benefits from this.
Yeah, exactly.
Cool. Well, thank you very much.
That's all right.
That's awesome. And I guess we'll call that's a wrap, and we look forward to seeing you next time. And that's a vet wrap. Join us fortnightly for these podcasts. You can access them through our YouTube channel, Education Hub on the Peninsula Vet Care Emergency and Referral Hospital website. and all other platforms that you can source your podcasts.